So good afternoon, LINNC Online. We are here in another interview session. So we have today very special guest for this interview. We have Professor Dr. Satoshi Tateshima from the UCLA University. He's a professor of radiology and neurosurgery, and he has been involved in several trials and research in the stroke field, in aneurysm flow, in dynamics and other neurological disease. So welcome.
Thank you. Thank you very much.
And we have also Dr. Charles Beaman. You are a neurology resident at Columbia University at New York City, and future stroke and interventional neurology fellow at UCLA. So welcome also, Dr. Beaman.
That's correct. Thanks for having me. It's a pleasure to be here.
Today we're going to talk about a very interesting article that you have recently published. You have published two nice papers that we are going to start with the one that you have recently published. It's a review of the robotic interventional neuroradiology. So my first question is, what is really robotic interventional neuroradiology?
So I suppose I can start. Dr. Tateshima, please feel free to chime in whenever. But basically the idea behind robotic neurointervention or interventional neuroradiology is to use a robot to help assist to conduct procedures in neurointervention. And I guess dating back the etymology, the term robot, basically you have a programmable machine that can help you in some way. And it's sort of a broadly used term, robot, but the general idea behind it is that you're using a machine to help you either automate or using remote control to help you do something. So this can be, as simple as cleaning hospital floors, flying drones, but in this case, it's using a robot to help us assist with neurointervention procedures. And generally, at least the commercially available tools at the moment consist of sort of two components. One is a patient side robot, which is consists of an articulating arm that's connected to the patient, and it has all kinds of motors and drive mechanisms to help conduct the procedure. And then there's more of a kind of a cockpit side that's being controlled by the neurointerventionalist. It's usually lead shielded, and it can be located either in the same angio suite, or it can be, theoretically conducted from a distance using remote teleoperation. And that's kind of the basics behind, I guess, what robotic interventional neuroradiology is in summary.
Perfect. And when we see the actual development of this technique, of this technology, where are we now? It's an early development, or it's a middle, or how do you think?
I think it's very early for neurointervention. In the OR, I think they have more advanced system. The fact is, last 13, 14 years, they did, at least just in US, 1.5 million robotic assisted surgeries already. So we are trying to catch up, and the Corinda system is developed primarily for, I think, a coronary intervention, I would say. It's approved in US for peripheral IR2. No neuro approval yet. So what we do is just below the neck and also spinal angiogram, which we can talk later. So the system, I think it's still primitive, I'll say, but it's a good start. And what happened in the OR is going to happen to us, I'm sure. And given that's what's happening, I drive every day Tesla, and I rely on autopilot. So I'm sure that's the same thing is going to happen to our angio seat.
So you think that robotic interventional neurology is going to be an aid for you as an operator, or maybe it's going to be sometime in the future a standalone machine, or both?
I think both. Charles, how do you think? I think we're on the same page, right?
I mean, I think I'll echo, what you said about we are sort of at the very, very early stages of the this technology, especially in neurointervention. I think the core path, which was one of the first big machines in coronary intervention, came out in 2012, and then in I think it's 2016 to 2018, the next generation device came out, and this was all really geared toward coronary intervention. So a lot of the tools and setup, it's geared that way. So I think we're pretty far from, you know, some sort of fully autonomous system conducting the procedure, but you know, that might be in the far distant future. But now I think it can be used as an aid, and I think I mean, Dr. Tateshima can talk about, I think, some of his experience with the machine, but at this preliminary stage, there's still, I think, many technical limitations that sort of preventing, you know, further adaptation, things like device herniation, you know, and just some bugs that inherently are going to happen with the sort of first generation devices. So I think we have some ways to go, but there are some exciting things on the horizon that I think will help aid procedures.
And as you said, are the coronary or peripheric more advanced than neurology, or we are in the same level, or you're using the same machine as they are?
I think you know, they are more advanced in a way in terms of the experience, but you know, we're gonna soon have a neuro-interventional Corindus robotic system. So with that, I'm sure we're gonna be catching up. But you know, using a robot for at this point the cerebral angio, carotid stenting, and some minor MVOs and the spinal angiograms, I think we exceeded the 50 cases now at UCLA. The very interesting thing is what we do, what we use for robotic catheter manipulation in terms of their devices, and what we use for hand regular conventional intervention, they are quite different. Partially due to the, I would say, a compatibility with the robotic system and you know, certain devices, but you know, certain latest devices, for example, you know, certain wires, very talkable wires, they're great, and we thought they were really good for robotic intervention, but not necessarily. So, you know, what works in our hands do not necessarily work in the robotic system. So in the future, now, you know, we're going to continue to use our hands for a while, but in the future, if you know, robotics becomes our primary tool to treat patients in our angiography, I think we have to have a robotic specific you know, catheters and the devices.
So how much time it takes to train an interventional neurologist to use the robot?
Great question. We do not know, but now our current fellows, after we did, you know, faculties and the staffs finished our first 5 cases, we switched our training to the fellows, and they're, I think, they must be feeling comfortable controlling robot. So for those who have catheter experience, manual catheter experience, I think 5 to 10 cases, they can learn how to use robot. But at this stage, I think it's more important to learn how to manipulate the catheter and everything manually and translate that experience into robotics. For that, 5 to 10 cases, I think, is a good start.
So when you have many cases in the normal, in the regular way of treating patients, you have the feeling that so you can lose this in the robotic experience. Like you don't have the haptics.
Right.
What do you in that field? What is going on in that field? It's a problem.
I'll say it's always good to have a haptic feedback. That's you know, of course, you know, good to have. But in the OR, that was one of the first issues or concerns they raised when they adopted you know, robotic technologies. But you know, for example, actual open surgeons like urologists, for example, they use robotic system quite often, and instead of just haptic feedback, they now pay more attention to the tissue deflection or shadows, you know, a lot of other things. So some of the haptic feedbacks can be replaceable, to be honest, I think, even in our angio suite. But, you know, certain things like, you know, suturing the, you know, tiny knot, you know, you may have to rely on the haptic feedbacks. So, you know, similar thing is going to happen to our angio suite. But, you know, for example, when we did our first spinal angio, I believe that was world first spinal angio using robotics. Instead of, you know, relying on haptic feedback, by just paying very, very close attention to the images and the catheter deflection, which I didn't pay that much attention before, while I was relying on haptic feedback, or just push the wire out of a catheter and just paying close attention to the wire motion. If the wire goes into segmental artery, it just goes straight. But if I'm out or I'm not engaged, it just goes up and down. We call wag technique because it's like a wagging a tail. So, you know, we just pay more attention to the images, and then some of the problem can be solved, I think. But again, we all, you know, as a society, we have to learn what's the best and what kind of technique we can develop.
So as you said, it's very interesting what you have recently published. I think 1 week ago, or this was the first cases of spinal angiography done by this robot. So that's congratulations for that. And as you said, when you were using this this microwire, it's an 018 microwire, and or it's a
yeah. So 018 wire, we use that for arch to the great vessel manipulation instead of a 35 wire. At this point, the robotic system cannot take 35 wire from the main port. From the device port, yes. But for spinal angio, we use 14 wire. It is just to stabilize the catheter placed in the segmental artery, and also it is to confirm the catheters, you know, engaging in the segmental artery. For that, then 14 wire, I think, is enough.
And you're using the contrast with the wire inside, or you're pulling out the wire.
Yeah, correct. So usually for the manual spinal angio, we use a contrast to confirm, and we manipulate catheter like this. But the robotics contrast injection, at least in our setup, we use manually. So it's better to use a wire to confirm we are in the segmental artery rather than manual contrast puffing, because we can then do everything robotically. And the robot can manipulate the catheter and wire, you know, without problem altogether. You know, we just control the joysticks.
Do you think you can be more accurate with the robot, with the use of the joystick and the robot? You foresee some specific use for that? For example, tiny aneurysm that you can enter the sac in a 2 millimeter aneurysm. Would it be more precise?
That's my speculation, because I didn't treat aneurysm. It's only, you know, we have to go talk to Victor, Vitor Pereira. But I think I'll say yes, because, you know, for example, there are certain functions for current coordinate system. For example, if I hit the switch, the wire rotates, flips 180. You know, it takes a lot of tactile feeding, but the machine does that, and you know, a lot of automated functions. We don't have to teach ourselves, our fellows, how to do it. The machine knows how to do it. So I think that in terms of accuracy, if we push coil 1 millimeter, certain people may not have that kind of a fine skill set. But you know, robotics is easy. Just hit the button, or you know, click on the touch panel, then the machine does that job. So I think yes, robotic intervention could enhance the accuracy of the procedure.
And I'll just add that, you know, I think they're working on several automation techniques. The coronary field also has developed some patented technologies, but different things like rotating the wire on retraction. There's things like basically a push-pull mechanisms that are built into the system that can help you advance through lesions. There's potential for sub-millimeter precision. So, I mean, things that you really couldn't do with the hand is possible. There's other techniques like kind of a constant speed. If you want to move the catheter wire at a very constant velocity, that's achievable, which probably the manual control wouldn't be able to do. And I think on the horizon, there's obviously opportunity for more advanced techniques and using machine learning algorithms to try to even improve on what humans can do. So I think there's some exciting things coming along these lines.
For sure, and you were also talking in the paper about machine learning or deep learning or artificial intelligence. I think it's in the line that you have been talking. It's learning things or learning patterns that can be used.
Yeah, definitely. It's an exciting area of research technology. It's sort of exploded over the last 5 or 10 years. And I mean, the principal idea is that you take very, very large data sets and you use them to train algorithms to try to achieve certain outcomes. So it could be that the machine is monitoring how you're performing, and it might learn from a large data set of your performance and actually sort of optimize how you work with the robot. It could also, over thousands of procedures, really learn sort of the best techniques to coil aneurysms or do thrombectomies based on big data sets. It's still very early, and there's a lot of barriers, I think, in place to achieve some of those outcomes, but it's certainly a possibility. I think if you can break down some of the barriers to sharing digital information and health data, but it's been challenging. We've seen it in radiology. I mean, even trying to read a chest x-ray accurately can be tough. So I think the idea of a machine performing procedure using these algorithms is another level. But it's certainly, I think, within the realm of possibility.
So last year when I first read about what was robotics, or the first papers published on more in interventional neurology, I thought, whoa, maybe we can treat patients in distant, in far away or in other places. That's not like that. That is still robotics. Or well, what do you think about it? Maybe we can treat stroke in another country or another city. Or...
Yeah, it's a huge possibility, and I think it's actually one of the things that got me very interested in the idea of robotics and neurointervention, because we have this gap in treatment for patients with acute vascular problems, whether it be stroke, thrombectomy, aneurysm coiling. There's a huge proportion of at least the population in the US and I'm sure across the world that doesn't have access to care. And telerobotics definitely has the potential to fill some of these gaps. I mean, I think in the US, I think only 20% of the population is within sort of a reasonable drive to thrombectomy capable centers. So you can imagine that with the growth of telerobotics, you could expand, that access to care pretty dramatically. And then I think the other sort of exciting part about that is there's also really not enough neurointerventionalists to do these procedures nationwide, and opening up sort of this geographic barriers with telerobotics can give sort of small communities or patients that are living in more rural areas access to very highly trained proceduralists. And I think the outcomes, are pretty dramatic after something like thrombectomy. So if we can, spread that to these patients, I think their clinical outcomes could really improve. So it's exciting. It's exciting.
It's very exciting. So we still have to rely in someone, some human, in the local, near the table. You have to be near the table, or you have to do the puncture. You have to put the introducer, or set the machine. Or what else have you? You have to be near the table.
Right. Yeah. So somebody has to puncture. Somebody has to put a catheter for us, here's the thing: we don't know how much we can do yet with the robot. So at this stage, at this point, we are trying to find out what we can do with the current system. So let's say somebody has to put the sheath for us, and somebody has to put the catheter, but does that person, who's physically standing right next to the patient, does that the doctor have to put the catheter in the neck and we take over, or we can put the catheter in the neck and do everything after puncture? I think the access is a part of skill set. And it's best to be done by fully trained neurointerventionalists instead of relying on somebody there locally who doesn't know little or if anything or nothing about neuro. So that's why we are manipulating catheter from growing above to the neck at this point, because it's FDA approved to do so. And surprisingly, 70% or 80% of cases, we can put the catheter up to the neck. So I think with a future version, there is a good possibility that we can, after growing puncture, we can do the stroke treatment. Of course, somebody needs to replace our catheter or put the stroke treatment or feed the, let's say, stent retriever to the microcatheter or set up the robot, that kind of things. But as far as the actual manipulation, I think we should be able to do the vast majority, even as is. In a couple of issues, the table control, I wish we could move the table, and it's possible to move the C-arm. Certain US centers with a Corinda system, they have also C-arm controlling capability. We don't, so we have to ask somebody inside or outside a technician to move the C-arms. But that's gonna that can be solved. But the table motion has to be able to, we have to be able to control the table motion for remote, I think, intervention, robotic intervention.
And I'll just add one thing, is that the other thing that we've yet to figure out is if the procedure goes badly, if there's a complication remotely. I think it's unclear at this time how that's going to be dealt with. If there's no neurosurgeon on site, if there's something that's never been shown to be completed with the robot, then it could be dangerous. I think as of now, no one's really, I think, treated a complication with using the robot. The complication rates have not been high, but I think it's something that we'll have to see to feel more comfortable spreading this out nationally or internationally, finding some mechanisms to deal with those things.
Yeah, that's a great point. Great point. Yeah, so I think we can now really replace everything with a robotic or telerobotics, right? Certain cases, for example, like aneurysms, instead of do everything robotically and a complication happens, then the patient dies. I think that's not acceptable. In aneurysms, those patients, we can wait. So those patients should be maybe transferred out to in-person procedures because we can do more in terms of complication management. But the thrombectomies, oftentimes, or vast majority of cases, we cannot really transfer out those patients, particularly certain area in the US. And even considering unfortunate complications and what we can do with that, with those complications, may be really limited. But statistically, it's best to be treated right there, given the procedural effect on the outcome. So I think we have to choose what procedure can be justified for us to use telerobotics, and what should not be telerobotic type of procedures.
Sure. So maybe we will need new laws or new rules for this new technology. Maybe like telemedicine, in one time we will have to face that, who is in charge.
Yeah, right. I think it's, yeah.
Sorry.
I was going to add, one of the nice things is that there has been this infrastructure of telestroke. So I think there is a way to sort of build on top of that, that infrastructure, maybe to spread telerobotic therapy for thrombectomy. But there are still some legal and sort of barriers that we don't fully have understood. You know, there's treatment across state lines, treatment across international lines. You know, I don't think anyone's broached those topics, but I think it's something that you know, should be figured out. The nice, you know, one silver lining, I guess, of a pandemic was that telehealth itself exploded. It was already growing, like one of the fastest areas of growth in healthcare, but it did allow us to, I think, transition a lot of healthcare to the telecommunications route, and it's helped to put in place some of these sort of security measures to help patients, which I think are very, very important, obviously, if we're going to be doing procedures from a distance. So it's I guess one silver lining to take away from a very tough year.
Do you think that we still have a very big gap about security in doing something distantly? For example, we have a reliable network for doing a telerobotics.
I don't know. Have you come across that, Dr. Tateshima?
Yeah. So actually, the remote procedure has been done. You know, it's been published already. It's been done in India in the field of PCI, and during that actual, I believe, 4 procedures, the operator did not, according to the paper, according to the company people, they did not even feel the lag or delay. With a reliable optic fiber, or now we have a 5G, I think that should be enough according to the company. But you know, we have to have a redundancy, because it's just an experiment over there in India. You know, they did remote telerobotics, but at the same time, you know, there were cardiologists standing by locally who, you know, were totally capable of doing the procedure, you know, right there. So in the future, if we really have to rely on the robotics system alone for the procedural success, we have to have a redundancy. The one system doesn't work and another system kicks in, like a airplane system.
So what is also very interesting, as you mentioned in the paper, is telementoring. It's helping someone that maybe he hasn't got too many experience, and you can be helping him with a robot. Is it that possible now?
I think so. Again, everybody has to have the same robotic system. That's the, I think, the issue. Now only I think 60 or 70 Corinda's robot in operation in US. So we gotta have the same robot. But yeah, it makes sense. Now we can connect ourselves online. And for example, I think you see LA, Los Angeles, and you see San Francisco. We're gonna get connected because we are gonna have a Coindas robot. We have a Coindas robot already, but they're going to have a Coindas robot. So we're gonna connect our robot in the same university system and apply medical procedural privileges each other, and then we may be able to start from there, and then we can learn how to coordinate, how to participate, to the case remotely. And once we accumulate that kind of experiences, then tele proctoring or robotic proctoring, I'm sure it's going to be feasible.
For sure. So we as an interventional neurologists, we are very prone or very affected with radiation. So putting out the interventional neurologist out of the block or out of the angio suite, it sounds very nice. You have detailed that there's a very important dose reduction for the manipulator.
Yeah, I think one of the big studies actually was done here at Columbia in the coronary field, and they showed, at least for the operator, like 10 times reduction. It's really just almost complete reduction in radiation to the operator, as you can imagine, because they're mostly standing outside the room or in a lead shielded cockpit completely away from the radiation source. But the interesting thing also that came out of some research was that the radiation level to the patient was actually decreased as well. And there was some question about why that would be, because sometimes the procedures are not necessarily shorter, but they think it may be related to where the table height position might be if it's using the robot versus the actual human operator. So I think it's promising, because obviously we all know about some of the occupational hazards, not just radiation, but wearing heavy lead and orthopedic injuries as you get older. There's atherosclerosis that can develop, cataracts. So the idea of doing maybe a potentially safer way over a long career could have positive effects. And then lastly, I'll just mention that the field is mostly male dominated, and I think that's probably a multifactorial cause. But one of the cited reasons that it's said in the literature is that it may be related to fears of radiation during pregnancy, and I think anything that can help bring some equality to the field is a positive thing. So yeah, I think it has a tremendous opportunity there.
I absolutely agree. For the patient, spinal angio or cerebral angio, any intervention, that's once in a lifetime thing, but it's everyday thing for us, right? And particularly spinal intervention for neuro, we receive less scattered radiation because we are radiating less body mass part. But for example, spinal angio, we have to stand right next to the scattered radiation source, radiating into the large body mass. So inherently, we receive a lot of radiation, and we repeat many angiograms, as we all know. So it makes sense for us to use those high occupational hazard, a lot of occupational radiation exposure to be replaced by robotics to begin with. And also, we have to have one person at this point in the room, but that person, the physician, doesn't have to stand right next to the patient. As if we do spinal angiogram, for example, manually, as we all know, we have to stand right next to the patient, growing and manipulate. But having a robot, that operator can be standing outside of the room or sitting on the chair and manipulate the catheter. And one physician who has to stay in the room can also stay away from the radiation source. So actual radiation that the person in the room receives is theoretically it's almost like a 1/10 of the radiation dose. So the radiation dose reduction to us is very important. The robotics makes a huge impact on that.
Great. So how far in the US we are from neuro procedure clearance?
I think we were expecting this summer. First, they were planning last year, but it didn't happen. And this summer, at least within a year, I think.
That would be great. So finally, what would you expect from the coming years in this technology in the next 10 years? What would we should expect?
Yeah, I think I'll just weigh in a little bit. I think it's, just to echo back on how we started, I think we're at the very, very beginning of a new technology, and there's a lot of promise, but I think, we need to do the work, the studies to try to see how this can be implemented safely. And, but I think there's some really, really exciting areas of research and progress that we're going to see in the next few years, whether it be things related to automated movements and techniques to improve precision and safety, to decreasing radiation, to enhancing telehealth and telerobotics, and expanding access to care. But I think, there's only been about, I think you can count the number of studies, case reports really, on your hands that have been completed and published in the literature. So, but it's really picked up the last few years, really the last year or two. So, what I hope to see is more and more people excited to buy it and more access to the machines, and I think we're going to see some really exciting things coming soon.
Yeah. So essentially, we share the same view. That's why we worked on the same review paper. We are here robotic believers, so I'm sure this is gonna be the mainstream. When and how soon, we do not know. But again, repeating the same thing in the OR last 14 years, 1.5 million cases already done robotically, right? So there is no doubt same thing is gonna happen. At what scale, I don't know, but same thing is going to happen to us. And radiation dose, reduction, accuracy, and no geographic boundaries. I think robotic can give us a lot of freedom and a lot of options, a lot of capabilities. And it's just us, who's going to have to adjust ourselves. We have to adjust ourselves to the new way of treating patients, changing devices, developing devices, developing new techniques, and developing new techniques. Yeah, here's the key. It's just now us, only a few centers participating or using a robotic system. But even at UCLA, I used it and my colleagues used it, and when we discuss about the techniques and which device worked the best and things like that, then that enhanced our knowledge, and we got better. 5 or 6 of us just discussing, and can you imagine? Every one of us, all of us here owns the robot and share the case experience, and the actual knowledge and the actual progress in this field is going to be exponential. So I see a bright future in this technology.
Do you think that you need more interaction between the device manufacturers or machine manufacturers of the angiograph and the robot? It still need some bigger interaction?
I'm sure, yes, definitely, and many manufacturers, like big players, they are aware, and they must have played with the robot, and they have to coordinate, and not just the robotic manufacturer, angiographic equipment manufacturers, and us, and the device manufacturers. Everybody has to participate in this act, and then make something really good, ultimately for our patients.
So thank you for sharing this fantastic technology. It's fascinating for me, and I think for everyone hearing this. Thank you for your work and all that you've been done and writing. So nice to have you here, and nice to talk with you.
Thank you very much. It was an honor.
Thank you very much. Yeah.
Have a nice afternoon.